So this study was performed in Australia, and it consists of an extremely broad patient population suffering from multiple different types of chronic pain conditions, prescribed a variety of opioid medications. It is the longest running study to date examining the long-term effects of cannabis on populations prescribed opioids for chronic pain. The goal was to determine whether cannabis played a role in pain relief in populations using opioids. They also set out to determine whether cannabis use in this population played a part in reducing or stopping opioid use to manage pain. Subjects had to have been treating their condition for a minimum of 6 weeks. The median duration of time dealing with the pain condition was 10 years. There were around 1,500 people recruited to take part, and in a nutshell, the methodology is this. Subjects were administered a baseline interview over the phone or in the form of a paper questionnaire. This was followed by several follow-up interviews 12 months apart for a total of 4 years. The interview assessed a subjective rating of pain severity, pain interference, pain self-efficacy, and depression and generalized anxiety scores. Subjects were asked about cannabis use and, through the author's statistical analysis, were placed into groups based on how often they used cannabis and for what reason they started use. If the subject had stopped use at some point during this 4-year study, they reported the reason for stopping. Those who'd used cannabis were asked how effective they believed it had been. General interest in cannabis use was determined when participants admitted use in the previous 12 months by asking, for example, if you had access to cannabis, would you use it? Pain self-efficacy refers to the degree of confidence that a person has in their ability to carry out normal everyday functions, while pain interference is the degree to which pain interferes with such normal function. Pain interference was measured by asking about difficulty maintaining working ability, daily living, a normal amount of sleep, and normal social interaction on a scale of 1 to 10. They were also asked about their painful condition during their lifetime and in the past year, how long it had been bothering them, and if it's neuropathic or nociceptive. Subjects rated cannabis's effectiveness as a 7 out of 10, but average pain severity scores, pain interference scores, and generalized anxiety scores were elevated among those who'd reported cannabis use. Pain self-efficacy was lower on average among those who'd used cannabis, albeit to a fairly small degree given the risk ratio is very close to 1, and that means that there wasn't much difference between those who had taken or not taken cannabis. Some common reasons for starting included general relaxation, 65%, pain-related distress, 73%, to treat pain, 83%, or to improve sleep at 63%. Some reasons for stopping included side effects at 23%, legal concerns at 22%, difficulty accessing cannabis at 20%, and of course 12% due to ineffectiveness. At the 4-year follow-up, around 30% of subjects that had used cannabis in the past month had sometimes or regularly decreased their opioid use while using cannabis. Among those who had taken cannabis at different frequencies, there was no significant difference in the amount of equivalent morphine taken across the patient population, or even the proportion that had stopped using opioids altogether. They used this partially to make the claim that they did not observe any opioid-sparing effects, which means a synergistic effect between cannabis and opioids that allows for less opioids to achieve the same therapeutic effect. They do mention that those who'd used cannabis less frequently were, quote, less likely to discontinue opioids at 4 years, 9%, compared to those reporting no use at all at 21%, despite no difference in oral morphine equivalent at the 4-year follow-up. We did not detect an association between cannabis use in the previous wave and reduced oral morphine equivalent at subsequent follow-up. We found no association in the univariate model and no independent association after controlling for other variables, which is to say that cannabis use did not cause people to use their opioid medications at a diminished rate. They go on to say that they did not find any evidence linking cannabis use to stopping opioid use. The researchers also attempted to determine an association between reported cannabis use in the previous follow-up interview and an increased pain interference score in the next follow-up. Quote, people who had reported use of cannabis at the previous wave had greater pain interference at subsequent follow-up than did those who had not used cannabis. In adjusted models, after controlling for age, sex, previous pain interference, pain factors such as duration of pain, pain severity, and pain self-efficacy, and oral morphine equivalent, previous cannabis use was not independently associated with current pain interference. In other words, those who'd used cannabis in the previous wave had higher pain interference scores the next time they were interviewed, but that cannabis is not independently responsible for this change. So the first thing I want to address here is the legal situation in Australia during this study. Participants only had access to illicit cannabis during the course of the study, which could raise problems with consistency across the patient population, because there's no transparency in the product used, the proportion of therapeutic compounds like THC and CBD, the purity of the product, and just the fact that there are differential applications of these compounds when used at different ratios and by themselves. Side effects are different as well between just CBD and THC alone, so this is only effective in a black market context, such as pre-medicinal system, which was established in Australia in 2016. It's very hard to nail down what exactly caused the side effects that 23% of participants reported as the reason for stopping use without this standardization. In addition, 42% of the patient population that had stopped using cannabis reported doing so for concern about legal repercussions and because of difficulty accessing the drug. This taboo and scarcity would not be the case in a clinical drug trial, for example. There are multiple types of pain as well, and to group nociceptive pain patients with neuropathic pain patients while not monitoring any physical manifestation of any particular pain condition, such as inflammation or behavioral hypersensitivity, is at best short-sighted. This kind of research is being done in animal models, so learning how this translates to humans would be important going forward, but it would require a much more stringent experimental design. Not only was the inclusion criteria broad, which makes the results harder to refine, but there was nothing stopping patients from using cannabis if they had not initially been using it, or nothing stopping them from stopping use at any time. There was no distinct control group, and those who had stopped using cannabis were not taken out of the study. They had to find a way to control for different variables statistically, but given that the patients' clinical profiles were so diverse, it would be very difficult to compare like to like in regards to what a given outcome means to each respective pain condition. There is a reason why clinical trials, even in a drug trial that may mean life or death in the event a person receives a placebo, that there is a defined control group. Without it, you can't draw a causative association between the drug and the side effect, or the drug and any therapeutic effect. Since there was no standardization of either, it's hard to say anything at all from these results for certain. When determining a drug interaction, it would also be important to control for the individual drug in question, because when you have a patient population taking a variety of different drugs, it's very hard to draw any conclusion on one drug or another, just given that data set, especially when there's no standardization on the drug that you're testing interactions with, in this case, cannabis. On one hand, the design for this study is important in assessing any broad consequences of self-medication in a diverse population, but given that this is outside the instructions of a doctor and the existence of a legal framework with which you can verifiably use a drug that you know the composition of, it's hard to generalize this to how it would play out given how a regulated market would operate. This isn't a clinical trial, and while it might be a good place to start and could guide future research in a more defined way, the claims being made about the study are at best premature and require this more specific research to take place. It's just too early to say whether cannabis has no positive effect on chronic pain patients, as some outlets are saying, or for that matter that it hurts patient outcomes. You can't believe everything you read at face value without digging a little deeper, and it's through looking at the minutiae here that really makes the difference in whether or not you can compare the consequences surrounding this study to a more regulated medicinal market. In my opinion, you can't believe this study at face value without further investigation because it's not measuring individual pain populations or medications. Nothing is standardized. The scope is much wider to determine the effectiveness in the context of a diverse range of conditions and medications, but clinical trials don't work that way, and you can't claim to not find any high-quality clinical trials and then go on and conduct a study that casts as wide a net as this study does. I'm not saying they're claiming this study as a high-quality clinical trial, but the conclusions being as definitive as they state them to be is, in my opinion, a little intellectually irresponsible.